Everybody is aware about osimertinib. I will not go into the details. So we will be speaking, we will be discussing about the real world evidence, and this osimertinib has been tried. So everybody knows that in EGFR we have first line, second line, third line TKI, and osimertinib, which is a third line irreversible third generation TKI. It has demonstrated significant improvement in the progression-free survival as well as overall survival. So it has actually shown more than 50% reduction in the risk of progression and up to the tune of 20% reduction in the risk of death by using osimertinib as against the first generation. It has been tried with against the erlotinib and gefitinib. So this is the pivotal trial of by Dr. Suresh Ramalingam. Osimertinib has been compared with the first-line EGFR TKI in advanced and metastatic NSCLC adenocarcinoma who are EGFR positive. I will not go into the details of stratification, but just look at the inclusion criteria. As we mentioned about the clinical trials, and they happen in a strict environment. So what percentage of our real-world patients represent in the clinical trial is a big question, and it is less than 5%. So if you see these patients have to have the performance status of 0 to 1, and they have included these actionable mutations, which is EGFR 19 and 21, and stable CNS metastasis. That means the patient has to have asymptomatic brain metastasis, or it should be treated with the radiation. And you know about its randomization, osimertinib versus first generation TKI, and the endpoints were PFS and OS. Again, coming back to the characteristics, the CNS metastasis was, in the inclusion criteria, it was a strict criteria, asymptomatic CNS metastasis or treated CNS metastasis. So the numbers are 19 and 23 in the standard versus the experimental arm. Most of these patients were fit and all actionable, that is 19 and 21, these are the only mutations included. So look at the PFS. So there is a significant improvement in the PFS and more than 50% risk reduction in terms of the disease progression. It is seen across the subgroups and the overall survival. You can see up to 3 years, 54% versus 44% patients alive at the end of 3 years. And the median OS is significantly improved, 20% reduction in the risk of death. So it added 7 more months by giving osimertinib as against the first generation TKI. So what's the conclusion? There is definitely a PFS and OS benefit, and the osimertinib became the preferred first-line treatment in EGFR positive, advanced and metastatic lung cancer. Most of the guidelines have all the options, right from gefitinib, erlotinib, afatinib, dacomatinib, but osimertinib has been given an edge because there is definitely, if somebody wants a better drug, you have a better drug, which is proven in a clinical trial, which is statistically as well as clinically meaningful benefit. And in both the setting, if you have, it is the preferred first generation TKI. Now, this is what happens in a clinical trial, which, as I mentioned, less than 5% of our patients who come to us in day-to-day clinic are represented there over there. So what happens to those patients who are excluded as per these clinical trials? In real world, you see 2 to 4% of the cancer patients receive treatment within randomized control trial, and thus raising an issue of representativeness. And this is very important question. Real world data have become useful tool. So what we do, we collect the data and we see actually what is happening. And it is something which we have to learn from this European country. This trial has happened in Italy, and we have such beautiful group in Pune. Now see, collaboration, bring so many people together on the same platform. So what they tried to do, they tried to do an observational study, prospective study, and these are the inclusion criteria. Fit patients more than 18 years of age, proven advanced or metastatic adenocarcinoma, EGFR positive, and upfront patients, first-line treatment. Those patients who received any clinical trial drugs are excluded. So if you look, the median age was a bit more as compared to the patients included in the FLORA study. So more elderly patients were included, nearly 70 years of age, which are usually excluded from the clinical trials. Brain metastasis percentage here was nearly 30%, which was less than 20% in the FLORA. And here the symptomatic patients were included, and more of an advanced disease as compared to balanced patients of advanced as well as metastatic disease in the FLORA trial. Now, endpoint. We usually debate about the PFS and OS, and this TKI, what happens, the biology of the disease, which are oncogen-driven disease, like EGFR. Sometime in our clinical practice, patients do progress, but they are asymptomatic. They have sometimes oligoprogression. Sometimes they have something beyond oligoprogression, but they are not symptomatic, and your TKI is working. You just manage that with giving SBRT to the oligoprogression, and there is a data discussed this ESMO by the European group where they have used SBRT more than 2 times and to control the resistant disease, and they have continued the actionable. They have treated the actionable mutations with the TKIs. So time to treatment discontinuation becomes an important prognostic endpoint in a real world. So they try to look at the median time to treatment discontinuation, which is measured from the starting to the day of discontinuation. What was the cause? And they looked at the various side effects, and they looked at the dose reductions as well as the dose delay, temporary or permanent, because of those side effects. In a pragmatic real world, this endpoint becomes important to assess the effectiveness of anti-cancer therapy in especially EGFR positive patients, and reflects the common practice what you and me do in our clinical practice. The other endpoints were survival and the disease control rate. And a very important point, which is highlighted at the end, is diagnostic therapeutic pathway. What we do, but we don't know what we do, is the day patient enters in your room, you do the investigations, you take the history, you send the patients for CT scan, then the patient goes to a radiologist for the biopsy, then the biopsy reaches to the pathologist. The pathologist gives the report. Then you collect the block, you send to a different laboratory, and then you get the NGS report. So this time frame is very, very important. Unless and until we as a clinician put our mind into it, we have a significant window of reducing this time. Sometimes those patients with poor PS, we end up in losing them. By the end of the month, we get the NGS report. So this is what they try to do. What is the time frame happens from 1 point to 2 the second point. The time frame between the diagnostic biopsy, histological report, proportion of patients undergoing the second locoregional treatment, and the rebiopsy, whether it's a liquid biopsy or a solid biopsy. So patients with poor PS, which were not included in the standard phase 3 trials, rare EGFR mutation up to the tune of 7%, mutations where the rare mutations which are usually not actionable are included in this analysis. Active brain metastasis, this means the patient has symptoms. These kind of patients are excluded from the clinical trials. And those patients, so the outcomes were exactly similar to the published data, thus adding consistency to their osimertinib treatment, even is those patients who are excluded from the clinical trial. No difference in PFS, time to treatment discontinuation, or overall survival noted in elderly patients, patients with comorbidities, and less common EGFR mutations. So this is the PFS analysis. This is the time to treatment, median time to treatment in all patients. The first one is in all patients. The second graph is those patients who are symptomatic versus those patients who are not symptomatic. So that also showed significant difference. So if your patient is asymptomatic, the patient gets more benefit. If the patient has less than 3 metastases compared to more than 3, the patients with lesser metastasis did well. This is again the same point. Patients with poor PS, comorbidities, rare mutations also benefited, even those with active metastasis. Outcomes similar to the FLORA studies. So there is no difference. So time to treatment discontinuation appears to be more suitable endpoint in clinical practice when you are treating your patients with all those problems which are excluded from the clinical trial. So time to treatment discontinuation was longer, 25.3 months in this particular observational study as compared to 20 months in the FLORA study. This might be because in the clinical trial, you have repeated scans happening, and the moment you notice that the disease is progressing, you change the line of treatment. They have defined line of treatment and eligibility for the patients. So this is something different which they see in real world. We tend to continue the treatment if the patient is comfortable with a lesser side effect. Obviously, osimertinib has a lesser side effect as compared to the other TKI and chemotherapy, definitely. Just going back. Okay. So I will not go into details of this. This is the univariate analysis and multivariate analysis of PFS, OS, and time to TTD, that is time to treatment discontinuation. In the in terms of PFS, OS, and TTD, only those patients who had symptoms versus no symptoms showed significance in all the three endpoints. Look at the responses. There were no complete remissions, but 73% of the partial responses, 23 stable disease, only 4% progressive disease. The median PFS was nearly 20 months, which is exactly same as the median progression-free survival of the FLORA study. Median overall survival was not reached at the time of data cutoff. This is those patients with brain mets versus no mets. Again, those patients who had brain metastasis, the median time to treatment discontinuation was 13.3 months, and those patients who did not have no brain mets, it was not reached. So that is another point. This we have already covered. So after median follow-up of 12.3 months, the median PFS was almost 19 months. Median OS not reached. The longer PFS was noticed in the absence of brain metastasis, as we just saw. Prolonged PFS and longer OS also noticed in patients without symptoms. Though asymptomatic patients, they get more benefit. Time to treatment discontinuation of 9 months or higher. So those patients who take treatment and discontinue beyond 9 months was significantly associated with the better overall survival. So essential element of evidence-based medicine is this diagnostic therapeutic pathway, which I was stressing on. And it helps to know the clinician to take a proper decision in the clinic. Among patients experiencing progressive disease, almost 50% underwent rebiopsy. The tissue biopsy was 66%, liquid was 28%, and molecular analysis was performed in nearly 60% of the patients. And these are the mutations which were the reason for resistance. Now, more important is the safety data. Those who use osimertinib must agree with me that it is a very safe drug. Fortunately, I have not come across any of the side effects in osimertinib. Venous thromboembolism, pulmonary embolism or DVT is seen in 10% of these patients. If you see any grade, it is 10%, and grade 3 and 4 is 8%. This is maybe because they have included poor PS, comorbidities, elderly patients. But this is one thing, important thing, venous thromboembolism, which was also seen in the previous trials. 87% patients experienced all kind of adverse events. 33% were grade 3 and 4, which is quite significant, which we don't see actually in our patients. Maybe our patients behave differently. Venous thromboembolism was the most common, and in real world, a stress study, a grade 3 PE accounted for 2% of pre-treated patients receiving osimertinib. No difference in the side effect, especially the thromboembolism reported according to the age, PS, comorbidity, tumor load. So again, the same point. No difference in survival outcome was observed when they compared age, comorbidity, type of EGFR. So you can give osimertinib to all the patients. Osimertinib confirmed effectiveness and safety in real world scenarios. So what we see in a controlled setting with the FLORA study, excluding those unfit patients, osimertinib, even if you give to those patients who are excluded from the clinical trial, it works. The study provides a real-world insight into the use of, and this is the only study which they looked prospectively, with the use of first-line osimertinib in patients with advanced EGFR mutation positive NSCLC. The efficacy and safety data supports the effectiveness and safety of osimertinib in real world. So this is my take-home message, and one thing is very important because we use all these molecules, but we never get the data together and we present our own data. These are very good platforms in every city, metro city. There are many associations. We can collaborate their data, and actually we can see what is happening in our subset of patients. That is very important. Thank you.